Hello, this is Brian, and I want to spend the next little bit talking about pericardial disease. So the objectives for today are going to be to, one, discuss the anatomy and pathophysiologic features related to pericarditis. We're going to talk about, we're going to identify the clinical and diagnostic features of pericarditis. And we're going to talk both about acute and chronic pericarditis. We're going to discuss the key differences between pericardial effusion and pericardial tamponade. And then we're going to describe the management strategies for the various etiologies. Now, the advantage of playing the, putting this on YouTube the way I am will be, or to perform this through Cam Studio, is that I'm going to play some different videos. And if you don't want to watch them, you can certainly fast forward through that. But I think I want to give you the opportunity to be able to see some different things that may help you in terms of delineating pericarditis and some of the treatment strategies as well as maybe potentially some various anatomic features. So just from an anatomic review, and this shouldn't take long, just remember that the pericardium is a double-layered sac. You do, just like with the pleura, you have a viscera and a parietal layer. The parietal layer is going to be the fibrous outer membrane. And remember that we know that the pericardial sac is fibrous in nature, so it doesn't lend itself to any type of give in an acute sort of sense. So you do have anywhere from 15 to 20 milliliters of fluid that does allow for frictionless movement and even up against different structures in the mediastinal area. It also allows this prevention of ballooning from occurring if you have somebody who is running or has some type of issue where they have sudden hypervolemia, sympathetic surge, or some type of dilatation of the cardiac chambers. That fibrous outer sac prevents ballooning out of those ventricles, which will help with cardiac function. And lastly, it does provide an infectious barrier so that if you have a pneumonic effusion, pleuritis, or some type of issue in the pleural space or the surrounding structures, that there is some barrier to infecting the myocardium. This is just a picture to show you that you have the chambers here, but you have the pericardial sac, you have the inner viscera layer, and then that's not fibrous, but then you have the fibrous outer sac, the pericardium as well. And then even within this blue area, which is the pericardium, you have a little bit of pericardial fluid. And we're talking only 10 to 20 milliliters at a time. So it's not much, but it does allow for this frictionless type of movement between the two pericardial layers. This is just another cross-section animated type of picture where the inner part of the myocardium, you have the myocardial muscle, you have the endocardium, and then the outer epicardium. And then as you get to this layer here, this is the inner viscera layer of the pericardium. You have the space in between, what we call the pericardial cavity here, where you have the pericardial fluid. And then you have the outer fibrous layer that is a tougher layer. Okay, so when you think about pericarditis, you're just thinking about somebody who has some type of inflammatory response that involves the pericardium. And if you look in your book on page 1972, this is the Harrison's Principles text. There are several different etiologies. You can have infectious etiologies, and you can have non-infectious etiologies. Coxsackie virus is probably one of the more common viral etiologies of pericarditis you can see, but you can certainly see it with tuberculosis. We don't see it as much in the United States anymore because of our treatment of tuberculosis and our eradication of tuberculosis. But if you have somebody who's immunocompromised, like an HIV patient who has AIDS, then you may see a tuberculosis type of setting. Fungal, again, you're going to see with more immunocompromised patients. And then certainly other infections, syphilis, those kinds of things are typically uncommon. Non-infectious, you have a fairly long laundry list of etiologies, and I encourage you to look through that for purposes of time. We'll talk about a few of these throughout the lecture, but I just wanted you to pay attention to the different etiologies of pericarditis. Okay, so when you're classifying pericarditis, then you think about, usually if you think of the number 6, then that gets you in the right ballpark. So if you have somebody who is less than 6 weeks, it's going to be fairly acute. Subacute is going to be 6 weeks to 6 months. Chronic is going to be greater than 6 months. Typically, the acute phase is going to be either effusive or fibrinous. And what I talked about in class is if you have a fibrinous sort of material that's causing pericarditis, that's usually an exudate of sorts that is in the pericardial cavity. And so if you think about somebody who's had a wound, like say for instance road rash or some outer wound where they have this exudate that typically comes from the immune factors that's working to repair the wound and causes the inflammation, then that is what occupies the space. Effusive is just that. It's an effusion or is fluid. So it could be serous, it could be sanguineous, especially if you have somebody who's had a recent surgery and they're accumulating fluid or blood, or you can have traumatic situations. Subacute is going to be constrictive, and so you start to see issues related to scarring. And we'll talk more about constrictive here shortly, or it can be a combination of effusion or a constrictive type of etiology. And then certainly you can see for chronic, again, you're getting into a constrictive type of pericarditis. It can be fluid, especially if you have somebody who has like a malignancy, or they have some reason that they reaccumulate fluid, uremic pericarditis. They can reaccumulate fluid even after it's been drained. And so in the chronic setting, you can see somebody who is effusive and then certainly adhesive, but again, that's not a constrictive sort of situation. So really, when you're thinking about the 4 principal diagnostic or clinical features, I didn't put the word clinical in here, but I would think about clinical features as well. These are the 4 things that you're going to be really looking for in anybody who is you're concerned about has pericarditis. And when I start to talk about this, some of the things that we're going to talk about can mimic a myocardial infarction. And so you really have to be able to discern whether or not this is an acute MI or is this going to be somebody who has pericarditis. And we're going to talk about some of the ways to delineate that. But as you go through this, you got to think about differential diagnosis, because you have to be able to think, okay, this is what may be going on. How do you start to rule out whether this is an MI or pericarditis? So the first thing we're going to talk about is chest pain. Obviously, there are several reasons people can have chest pain. So what are the unique characteristics of chest pain for pericarditis? Well, it could be retrosternal, it could be left precordial. It could be a constricting pain, especially if they have some constrictive effect of their pericarditis. It can radiate to either both arms, neck, or left shoulder. It can be certainly worse lying down, whereas when they're sitting up, the pain typically feels better. And if you think about, when you're leaning forward, you do have you do have less of a stress on the heart from a structural standpoint, from an anatomic standpoint, than when you're leaning back, and that's why you probably tend to find that you don't have as much pain. So again, how do you differentiate for chest pain? Well, it's really hard, because when you think about somebody having myocardial ischemia and you worry about whether or not they're having an MI or unstable angina, pain can be delineated several different ways. We know the classic is going to be crushing substernal chest pain, but up to 15 to 20% of patients can have reproducible chest pain. So, and reproducible we don't even think about with myocardial infarction. We think about things such as costochondritis or some type of musculoskeletal pain. But my whole point behind that is people are not a textbook, and so you have to sit there and think, okay, they're having chest pain. How does this relate? And if you think about the left precordial pain, the myocardium does extend off of the leftward from the mid-sternal area, And that's where you can see evidence of left precordial pain because it follows along where the left ventricle, because you're talking about the pericardium that covers the whole heart, including the right side and the left side. Okay, so the second thing that we talk about is a pericardial friction rub. And again, this can be best heard in the left lower sternal border. It can be heard as a grating, rasping, scratching sound, and it's best heard at end expiration. Although you can hear it through the inspiratory cycle, then it's actually heard best at end expiration when you don't have the effects of air that's inside the lung parenchyma. So my question to you is, how can you differentiate a pericardial friction rub from a pleural friction rub? If you're thinking about somebody who has a pleural friction rub and somebody who has a pericardial friction rub, how do you differentiate the two? Okay, and before we answer that question, I want you to listen to an 8-second video that I have where you can actually listen to what a pericardial friction rub sounds like. Okay, now, if you paid attention to this, all right, when you saw this go by, and you may need to play this again, the noise that you hear, the extra sound, is on top of the S sound, okay? Now, that can get confusing for a murmur, where you hear a murmur usually in between the lub dub. Remember, the lub dub is the S1 and the S2. But when you're hearing that wall motion occurring and you know that that pericardium is moving, then you have a tendency to hear this more associated with the S1 and the S2. Okay, so go back and listen to it if you need to. You have the YouTube the YouTube address here if you want to go back and listen to it on your own. Okay. So again, my question is, how do you differentiate a pericardial friction rub from a pleural friction rub? Well, when somebody's not moving air, you're not going to hear the rub, right? For a pleural friction rub. So a pericardial friction rub, their heart's not going to stop between inspiration and expiration. So you're going to hear this noise whether or not they're moving air or not. So that's going to be the biggest difference. Okay, so the next thing we want to talk about is EKG changes. So if anybody here or is listening to this has seen a 12 lead of somebody who has pericarditis, your first reaction is to think, oh my lord, they have a big MI going on. But if you think about EKG changes associated with an acute coronary syndrome, typically the changes are regional. Very rarely do you find somebody that has a global MI where they have involvement of the right and left main coronary arteries. Okay, if you do, that person is doomed. It's a very rare occurrence, and so typically you're going to find people who have regional variation of EKG changes, whether it's inferior, leads 2, 3 in AVF, whether there's some lateral changes at 1 in AVL or V5, V6, or it could be anterior in the precordial leads. Now, with pericarditis, you're going to find that EKG changes tend to be across all of the leads, or the vast majority of the leads. Okay, and that's usually due to the subendocardial inflammation that occurs. So now you're starting to get movement of that inflammation from the pericardium into the pericardial muscle, and so you're not getting changes that are associated with ischemia per se as it is. It's reflective of inflammation. So how the 4 stages you're going to see are, number 1, you're going to have widespread ST elevation across the EKG, and it's going to be fairly uniform across the EKG. But the next question is, well, okay, I have ST elevation. Well, how do I know that this is an MI versus pericarditis? Well, you have this concavity of the ST segment, okay? Well, what does that mean? And I'm going to show you a couple of pictures, but instead of you having this S wave and then all of a sudden there's a sharp movement back up before you get back to the baseline, you get this sharp movement back up into the ST or into the T segment or in the T wave. There's this sort of lag, and then it goes back up. And I'll show you on the next picture, on the next screen, what I mean. You're going to see this in at least 2 limb leads, and you're going to see this throughout the precordial leads. You can see T wave depression or ST segment depression in leads AVR and V1, but those are the only leads you tend to see it. Whereas in an acute myocardial infarction or an acute coronary syndrome, there's reciprocal changes in the area that is not immediately affected by the myocardial infarction. So if you have an inferior wall MI, typically you're going to see ST segment depression or those reciprocal changes in the precordial leads or potentially in the lateral leads. So this, you're only going to see it in probably no more than 2 leads, whereas the rest of the leads you're going to see ST segment elevation. Now, usually within several days, you're going to have ST segments that return to normal. And that's important because when you think about somebody who's having an MI, you're going to see within hours those ST segments return back to towards the baseline, whereas it's going to take more of several days with the pericarditis. You have after this ST segments return to normal, phase 3 or stage 3 is going to be inversion of the T waves, and then eventually within weeks to months you're going to have complete normalization of the EKG. Okay, so again, how does this differ from the presentation of an MI? We're going to talk about how it looks different on the subsequent slides, but again, these are changes that occur over days to weeks to months, whereas the changes in the ST segments typically occur in MIs or in acute coronary syndrome typically occur over hours. Sorry, guys. Okay, sorry about that, folks. I was just having some trouble here. All right, so again, looking at the changes that we're talking about, you're going to see we'll talk about 2 things. One, you can see this concavity here with the ST segment elevation. If you look at this next picture, and somebody who has pericarditis, then you can actually see this concavity that occurs where the ST segment falls below this line, okay, this linear line. When you have somebody who has an acute coronary syndrome, what you're going to see is that there's no concavity like you see here. That it's going to take off straight from the S wave into the T wave, or you may have this convex appearance of the EKG of the ST segment. So or of the T wave. There's this, in terms of the ST segment elevation, you're going to have, when the T wave starts to take off, you're going to have this convex appearance. So that's where the difference occurs between pericarditis and MI. The other thing that you're going to see here is, and I didn't point this out in the previous lecture, but you're going to see this depressed PR interval, okay, our PR segment. Normally with the PR or with the P wave going to the R wave, or potentially the Q wave, you're going to see the P wave come back to the isoelectric line and then take off into the QRS. With somebody who has pericarditis, you're going to have depression. If you have atrial involvement of pericarditis and inflammation, then you're going to see this depression of the T wave, of the P wave, once it comes back to the isoelectric line. So this is just another picture to look, and sometimes if you look, it depends on the lead that you're looking in. You have to be careful because you may think, "Ooh, I look at one of these leads and I see an MI." But what you're seeing is, one, you're seeing the EKG that's across all of the leads, and you don't normally find that in somebody who's having an MI unless, again, that you it's regional variation. Very rare to find somebody who has a global MI where they have involvement across all of the EKG. Again, very rare. I've seen it. It's just, again, very rare. The other thing that you're going to find, again, is in V1 and AVR. It's not always the case, but in AVR you have T wave inversion or the ST segment depression. You don't see it here, but again, you don't see the same level of ST segment elevation that you see in the rest of these leads. And if you look at some of these, like in lead 2, you do see some convexity here. It's just not the sharp takeoff that you would expect that we're talking about with the MI. So again, like here, there is a little bit more of a sharp takeoff, but it's really hard to tell, whereas here you tend to see that more. So that's why we call that pericarditis. Again, same thing here. You have that concavity here that we were talking about, and then again with the P waves, you're seeing that there's that depression that occurs. Again, just another sign that this person may have pericarditis. Okay, so don't be surprised if on your exam you see an EKG and I look at you and say, what do you think is going on here based on this patient's complaint? Okay. Okay, so the number 4 diagnostic feature we're going to talk about is the presence of an effusion. So this is particularly important, especially depending on the timing that the effusion builds up. If you have somebody who has a pleural effusion, then the thing you have to worry about is, are they starting to develop some type of restriction on systolic function? Or is there an obstructive inflow to into the ventricles? And what I'm talking about is tamponade physiology, and we're going to talk more about tamponade here in a minute, but that's what you have to worry about, because if this is an acute buildup, say if somebody was in a motor vehicle crash and they had a chest trauma where they had direct impact to the front of their chest, or if it's somebody who has had recent cardiac surgery and they've had manipulation of the heart and or the pericardium, then a small amount of fluid as low as 150, 200 milliliters can cause tamponade to occur. Whereas if it's more long-term or chronic, i.e. a malignancy or uremic type of effusion, then the fibrous sac over time can expand with that slow buildup of fluid to allow for that expansion, and so patients don't experience a tamponade. I've actually moved patients before in my transport experience who have had over a liter in their pericardial sac and need that to be drained, and you think, how can somebody hold a liter inside their pericardial sac? Well, it's because they have recurrent effusions and they have that buildup over time, and they can tolerate it till finally get to the point that the myocardium starts to suffer in terms of performance. You may hear muffled or faint heart sounds, and that's simply because you're listening through fluid, and that can actually muffle the sound quite a bit. So it's not uncommon for you to have a harder time hearing heart sounds. And the muffled is the characteristic description. You may hear disappearance of the friction rub and the apical sound. I put PMI down, but it's your apical pulse. Especially if you're auscultating, you may have some disappearance of that because of fluid buildup. And you certainly will see EKG changes, and we're going to talk about that. Now, if you remember EKG changes with somebody who has a pericardial a pericardial fluid or effusion, typically you're going to see this water bottle appearance on the chest X-ray. All right, so this is a normal chest X-ray, and what you see is you have the right ventricle or the right side of the heart here. You have the left side and kind of a normal silhouette. You have a little bit of obscurity of your apical or your aortic knob, but this is a fairly normal looking cardiac silhouette. Now, this is an X-ray that I retrieved from learningradiology.com, and what you see is you have a water bottle appearance, and this is just with fluid that has built up in the pericardial sac, and it doesn't go, the fluid doesn't go in one direction or the other. It goes around the pericardial sac. So, and remember, if the patient is sitting upright, then fluid's going to be the most dependent, which is downward, and so this is where you get that water bottle appearance. Again, another evidence of it, the water bottle kind of looks tilted towards the left a little bit, but what you see here is, again, that water bottle where you have the fluid that builds up and is more dependent with gravity. And so the problem with the pericardial effusion is you normally have a little bit of fluid in this pericardial sac, up to 15 to 20 milliliters. But as you start to build more fluid up, and depending on the timing, whether it's acute or chronic, you start to have movement restriction of ventricular performance, because you have this fluid that is within the fibrous sac. Remember, the fibrous sac, especially in acute situations, doesn't expand. So now you have this fluid occupying this pericardial space, or this pericardial cavity, and the only thing that can give it all is going to be the actual myocardium. So you're going to have a decreased space for ventricular filling to occur during diastole, so that when the heart pumps during systole, there's not as much fluid that's being moved either into the lungs or into the systemic circulation. So you have an inflow obstruction because you don't have the ability to fill, but then you have that decreased cardiac output because now the ventricles can't move forward and they can't pump fluid, the amount of fluid they normally pump, because there's just less space available because of all the fluid in the pericardial sac. So for diagnosis, when you suspect somebody has a pericardial effusion, the study of choice is typically an echocardiogram. And really what you're looking for, although it's not the most definitive test, it can actually help you determine whether or not there's fluid in the pericardial sac. And what you're looking for is this hypoechogenicity or a space with hypoechogenicity, or an echo-free space between the pericardium and the pericardial layer. You're not really, under normal circumstances, going to see a significant amount of space, or hardly any space, because there's such small amount of fluid in the pericardial cavity, and so between the viscera and parietal pericardium. So when you see that echo-free space on the echocardiogram, you have to be concerned that a pericardial effusion is present. Okay. You can see evidence of electrical alternans. This is probably another more EKG finding, not an echocardiogram finding. But what you can see is, if you look down here in the bottom right-hand corner, you have one EKG tracing where you have the normal EKG or QRS. The second one you have decreased voltage. The next one you have regular voltage, and the next one you have decreased voltage. This is again another sign that you may have somebody who has pericardial tamponade or pericardial effusion. CT or MRI can actually help you determine the chronicity a little bit more. And what I mean by that is, if you have somebody who has a chronic effusion, one of the ways that you're going to know, and especially if they have a constrictive component, is that you may see thickening of the pericardial layers. And so if you have that kind of situation, especially if you're worried that it's a constrictive pericarditis, then a CT or MRI, and I would probably choose CT first. I think for that kind of structural change, you're going to see pericardial thickening on a CT scan. Remember, when you're thinking about diagnostic tests, you have to look at cost, and you have to look at what information you're trying to get. And understanding the difference between a CT and MRI, a lot of times MRI may give you a lot more soft tissue information that's more precise than with a CT scan. Okay, but I can see pericardial thickening most likely on a CT scan. I can see loculated effusions. If I have somebody who has a chronic effusion, whether it's from trauma or uremia or whatever the case may be, and they have loculation where you have fluid that's walled off, and you can see that rim around the loculation on a CT scan. And what I mean by a rim is that you can see this sort of white layer going around where the fluid is encased. Then that is another thing you'll probably see more on a CT scan, and you are less likely to see it, or probably won't see it, on an echocardiogram. Okay, and again, if you have somebody who has a pericardial mass, you can probably better delineate this on MRI, but again, you can see the mass on CT scan as well. Okay, now that I know how, and I'm actually doing better in terms of forwarding my slides, I don't have to pause this lecture any further. So if I have somebody who has pericardial tamponade, then or an effusion, the next thing I worry about is, well, are they showing signs of the tamponade physiology? And that's what I term it. You have to recognize there's a difference between pericardial effusion and pericardial tamponade. Pericardial effusion is where you have fluid that occupies the pericardial space. Pericardial tamponade is where you start to have that pushing or that pressure up against the ventricles to the point that you start to have systolic function that is affected adversely because of that pressure up against the ventricles. And so it can be slight, it can be early, it can be, or it can be profound. I've transported 2 patients in my career that have had cardiac tamponade. One was mildly symptomatic, the other one was massively symptomatic, and he was being moved for purposes of definitive management. And I can tell you this is a very scary situation to be caught in, because there's not a lot you can do to treat the pericardial tamponade except for the definitive management. You can actually do pericardiocentesis if you're trained to do it. If you're not trained to do it, then obviously you can't do it, and then you're stuck with supportive management, whether it's fluids or whatever the case may be. We'll talk about that. Okay, I'm going to show this video real quick of pericardial. These are fairly short, but again, you can fast forward through this if you don't want to watch it. Okay, so just a little humor to point out that pericardial tamponade is a life-threatening emergency, and you need to be pretty aggressive in how you're going to manage it, or else this patient will die. So again, is there a difference? Well, I explained it earlier, and I won't belabor the point, but just remember that effusion is having fluid in the pericardial cavity, whereas tamponade is where you start to affect systolic function because of the effects of increased pressure from the fluid against the fibrous sac, and it's going to push up against the ventricles, and it's going to cause decreased filling during diastole. And because you have decreased filling, then you're going to have a decreased amount of stroke volume with each systole. So that's going to be the issue, and obviously the more fluid, the more pressure, the more pronounced the tamponade is going to be. So again, the effusion, a tamponade is going to be effusion with clinical effect of inflow obstruction to the ventricles, followed by, like I said, the decreased amount of stroke volume with systole. Common causes. I'll tell you that you will see tamponade in a lot of different situations. I'm a little bit more partial because of my background in post-traumatic or post-procedural bleeding. You can see that whether it's in cardiac surgery, which I don't have a lot of experience with cardiac surgery, but you certainly can see that if you're actually having to go through the pericardial wall and you're actually or pericardial sac, and to get into the pericardium or to have whatever type of cardiac surgery. And I think with the advent of more minimally invasive procedures, like valve surgery, those kinds of things, we'll see less of this. But when you're doing something that affects the myocardium, then you obviously run the risk of pericardial tamponade. So what are the clinical features of tamponade? So patients will typically demonstrate early with signs of tachycardia and increased work of breathing, and that's going to occur because the patient's going to be more than likely hypoxemic from the inflow obstruction, and so you're going to get backup of fluid into the venous circulation, both on the pulmonary side and on the systemic side. So these patients can become hypoxemic, and as a result can become tachypnic because their cardiac output is going down. They can become tachycardic as well. They can develop dyspnea because if you think about it, patients, as they are building more pressure up against the myocardium with all that fluid, then you're going to have fluid that's going to back up into the pulmonary venous side, and then they can develop signs of pulmonary edema. But again, if you think about the physiology behind it, that's critically important. Because if you think of somebody who has pulmonary edema, you don't want to automatically think, I'm going to treat them with Lasix. This would not be the patient to treat with Lasix, because that's not their problem. The problem is they have a form of shock that needs to be managed. Okay, so again, dyspnea, increased work of breathing, tachypnea, they're going to have those kinds of issues. Tachycardia, certainly because of the shock and decreased cerebral blood flow, they can become agitated and restless. And then another telltale sign is that they can develop hypotension. Now, again, diastolic pressure is going to be reflective of what's going on in diastole. And so if you think of somebody having an elevated pressure in diastole because of this fluid buildup on the heart, they can actually have a narrowed pulse pressure. It's not that uncommon to find that. And so versus a patient who has sepsis where they're vasodilated out and you expect them to have a low blood pressure, a low diastolic pressure, this patient can actually have a higher diastolic pressure. So it is not uncommon for this patient to have a pressure of like 90/70. They're going to have that elevated pressure associated with diastole. So classic to pericardial tamponade is something that we call Beck's triad. And Beck's triad is not about 3 beers named Beck's that are in a triangle, but it's certainly a clinical feature that we tend to see that's very classic to pericardial tamponade. So you're going to see distended neck veins, and you're going to see that because blood is going to be backing up. You get that inflow obstruction into the atrium ventricles, and so because you see that, you're going to see distended neck veins. All right, you're going to see that hypotension with that narrowed pulse pressure. It's not delineated on the slide, but think about that narrowed pulse pressure. So instead of seeing a blood pressure of 90/40, you may see 90/70. Okay, and because of the fluid, that's your interface between the heart and your stethoscope, then you're going to hear muffled heart tones. So again, Beck's triad is going to be muffled heart tones or distant heart sounds, distended neck veins, and hypotension. You can think it in terms of the 3 Ds if that helps you. That's certainly, there's again nothing wrong with that. Whatever helps you to remember this as the classic sign of tamponade. Pulsus paradoxicus occurs when you have a greater than 10 millimeter of mercury drop in your blood pressure during the inspiratory phase. The reason why that occurs is if you think about the negative pressure associated with inspiration, you tend to have your best blood flow into the heart during inspiration. Okay, it's just how fluid moves in that setting of negative intrathoracic pressure. So when you have increased buildup of fluid, especially to the point that you're reaching or you surpass that central venous pressure, then you don't get a tremendous amount of blood flow into the ventricles. You're getting into trouble. But as you get into that inspiratory phase, you're optimizing that time and you're facilitating right ventricular enlargement, and you're able to get fluid that can move. That's the time you're going to get the most movement of fluid into the right ventricle. Now, because of the normal physiology of the right ventricle sort of dilating a little bit to facilitate blood flow into the right ventricle, you're going to have this ballooning of the septum towards the left ventricular side. So you're going to see decreased systemic cardiac output as a result, and that's why you see that drop in the pulse, and drop in the blood pressure during inspiration. So you're going to get this additional dilatation of the right ventricle that allows more fluid in on the right side, or in theory is going to allow more blood in on the right side, but you get that dilatation, you get that ballooning of the septum towards the left ventricle, and as a result, you get decreased amount of filling in the left ventricle during inspiration. Because you don't have as much filling during diastole during inspiration, then obviously when you eject that blood, you're going to have less of a cardiac output. That's where you get that drop in blood pressure from. Okay, if you don't understand that, then I encourage you to let me know, and we'll watch this YouTube video real quick to bring this point home.
Welcome to the Stanford 25 video on pulsus paradoxus. Pulsus paradoxus is defined as a systolic pressure drop greater than 10 with inspiration. Normally, during inspiration, the decrease in intrathoracic pressure will cause an increase in blood flow to the right side of the heart, leading to an increase in pressure transmitted to the right ventricular walls. Since more blood remains in the lungs during inspiration, a small drop in systolic blood pressure is expected. However, in tamponade, the increase in blood flow and pressure on the right ventricle during inspiration cannot be transmitted to the right ventricular wall, and is in turn transmitted to the ventricular septum. This in turn leads to a decrease in left ventricular filling, which causes a decrease in stroke volume and a much lower systolic blood pressure. To measure pulsus paradoxus, all you need is a stethoscope and a blood pressure cuff. To test for pulsus paradoxus, slowly look for the first corticoff sound that will appear, then disappear during inspiration. Next, slowly listen for when the first corticoff sound no longer disappears with inspiration. This clip was recorded from a patient at Stanford University with a pericardial effusion. Pulsus paradoxus can be a valuable clinical tool and has been shown to have a sensitivity of 98% and a specificity of 83% in predicting cardiovascular compromise. Along with tamponade, pulsus paradoxus can be seen in some patients with constrictive pericarditis, during asthma or COPD exacerbations, and less commonly in other clinical scenarios. Importantly, pulsus paradoxus may not be present despite a patient being in cardiac tamponade in certain situations such as aortic regurgitation and atrial septal defect. In addition to other findings such as an elevated jugular venous pressure, tachycardia, and shortness of breath, pulsus paradoxus can serve to be a valuable tool in the evaluation of a patient with suspected cardiac tamponade. This has been the Stanford 25 video on pulsus.
Okay, so that's pulsus paradoxus, and I encourage you to watch that video to get a better understanding. I thought it was a really good video to concisely talk about pulsus paradoxus. Okay, so to diagnose tamponade, the echocardiogram tends to be the test of choice. You can demonstrate evidence of an effusion, And then you can see differences in flow velocity during the different inspiratory and expiratory phases of respiration. For purposes of this class, I don't really want you to go further into echo than to, unless you want to, than to talk about different flow velocities through the valves as well as the pulmonary venous circular or respiratory cycle. So I really would just leave it that simple. Again, I'm not here to teach you the in-depth ultrasound, but just recognize that ultrasound is going to be the test of choice and will demonstrate changes in cardiac function as well as evidence of the effusion. Okay, so first thing you want to know is how bad does this patient look? And that's probably going to dictate how urgent you need to begin managing this problem. Are symptoms present? Are they starting to show the tachycardia, which will probably be one of the earliest signs you see? You may see some signs of tachypnea as well. Remember, tachypnea is probably the principal or cardinal sign of critical illness. So do they show signs of critical illness? Are they tachypnic, increased work of breathing, tachycardic? If they're showing signs related to Beck's triad, or you're starting to see more profound symptoms, then something needs to be done more quickly than if you just wait. Obviously, the thing that you need to do is you need to remove the fluid from the pericardium. But if you're not credentialed or privileged to do that kind of procedure, whether it's surgical or which none of us will do surgery, or if it's not the pericardiocentesis, then you need to be able to support them. Now, I talked earlier about how patients can be tachypnic because of the inflow obstruction from both the pulmonary venous circulation as well as the venous side of the systemic circulation. So that would lead you to think, well, I don't want to give them volume because that's just going to make their pulmonary edema worse. Remember, their pulmonary edema is, or not their pulmonary edema, but their symptoms are not because they're in pulmonary edema because of the physiology related to pulmonary edema. The problem is that they're in shock because it's a inflow obstruction. So you want to be able to one of the things you can do early on is you can fluid challenge these patients, because what you can try to do, remember the problem is you've got this pressure inside the chest or inside the pericardial sac from the fluid that is accumulated, and the pressure has exceeded the pressure needed for inflow of fluid during diastole. So if you can increase their central venous pressure, then that may help to move fluid forward, and you can somehow fill the ventricle and be able to temporarily improve their hemodynamics. I would tell you this is a temporizing measure, and this is not going to definitively treat them. But if you're in a situation where you're waiting for somebody to show up who can perform pericardiocentesis, or you can get this patient emergently to surgery, then fluid challenge will probably be the way to go. Could you transiently make them worse? It depends. If they're bringing in more fluid from the pericardial tamponade, then certainly it may ultimately make them worse. But a lot of times, if they don't have this steady inflow of blood into the pericardial sac or fluid, they just have enough in there that you're inhibiting ventricular function, systolic function, then perhaps getting enough fluid into the central venous system to move fluid forward through the ventricles and into the pulmonary circulatory system and back into the left ventricular system is enough to buy them time. So it's important to understand that the problems are not typically related to, dyspnea is not from pulmonary edema, therefore I don't want to give them fluid. The problems are from inflow obstruction. So that physiology is important when you're talking about treating this patient. If you think this patient's in pulmonary edema and then you're going to give them Lasix, you can kill this patient. So you have to be very careful about understanding the physiology of why they're presenting the way they are, and how things such as a fluid challenge versus pericardiocentesis or your surgical options are warranted. I do have a YouTube video, and for purposes of time, I'm not going to go over this right now, but I do have the video here if you want to look at it on pericardiocentesis. This is essentially just sticking a needle into the pericardial sac to withdraw fluid. In certain circumstances where patients can have recurrence of fluid, you can actually put a catheter in and leave it in place to be able to withdraw fluid periodically. So the typical approaches are parasternal for pericardial centesis, apical. Most commonly, you'll see the subxiphoid approach, where you'll come from underneath the subxiphoid process or the xiphoid process, and you'll direct the needle in about a 45-degree angle to the left shoulder to get down to the pericardial sac. Okay. You can once you retrieve this fluid, you can actually do a pericardial fluid analysis, much like you would for pleural fluid analysis, to see if this is a transudative effusion, exudative. Remember, transudative tends to reflect a more systemic kind of problem, whereas exudative is more localized, whether it's a malignancy or some infective effusion or something that's occurring locally. And then, certainly if they have recurrence, then, or you're worried that they'll have fluid reaccumulation, then surgical options are certainly not out of the realm of possibilities, with performing a pericardial window, which is a small opening in the pericardial sac to allow drainage of fluid, or you can have pericardiectomy, especially if you have some situations related to like constrictive pericarditis, which we'll talk about shortly. Or you can just have a pericardiotomy, where you just create an opening, a more formal opening than a pericardial window. Pericardial window tends to be the least invasive of the three, although it is a surgical procedure, so you do have to go in. Okay, so next we're going to talk about different etiologies or reasons behind pericarditis, and we'll just briefly touch on your book. I did follow your book, so your book does touch on these different etiologies and how you go about treating this. So the first we're going to talk about is viral or idiopathic pericarditis. And viral, if you have somebody who has an idiopathic pericarditis, that is typically somebody who you've excluded other reasons, whether it's infectious or non-infectious, for pericarditis. So I think of idiopathic pericarditis as a diagnosis of exclusion. If there's just you don't know why they have this, but they have it, then it's labeled as idiopathic pericarditis. Usually viral occurs when there's been some recent viral illness that has been thought to have been caused. And the pericarditis tends to be caused by that same virus. It could be a respiratory virus or something that just gets translocated into the pericardium. Can be a viral pericarditis, can actually be your cardiac presentation of HIV. Remember that with HIV you have this immunocompromised state that progressively worsens over time, especially if it's not being managed pharmacologically. So you may find that you have an unusual presentation of pericarditis that ends up being your initial manifestation of HIV. So if you have a poor reason to think of somebody having pericarditis, especially if you fear it to be viral, then you may need to test somebody for HIV, especially if they have the risk factors for HIV. Again, idiopathic we talked about is when no other cause can be identified, and I would just strongly encourage you to use that when you've excluded other etiologies. So when you're thinking that somebody has pericarditis, you need to start going down your list of the differentials in there and to try to figure out what's causing the pericarditis. Okay, you can see here it's more common in young males, and again, just remember paying attention to the history when differentiating between pericarditis and MI. MI is going to be your sudden onset of chest pain. Sudden onset of chest pain, and we talked about this early on with when we started talking about pericarditis. Whereas pericarditis may come on usually related to some other condition. So it could be after an injury, it could be after surgery, it could be after some type of bacterial or viral infection. You may have associated renal failure and with a high BUN to demonstrate uremia. Somebody who has hypothyroidism and myxedema. So I mean, usually there's some sort of other component of a history that allows you to think about pericarditis versus an MI. So really with pericarditis, the treatment strategy tends to be supportive, especially if it's idiopathic or viral. For a viral pericarditis, you're not going to treat it with an antiviral necessarily unless there's a specific antiviral agent for the what you're treating. If it's HIV, then you're going to go the antiretrovirals, as we'll talk about in the HIV lectures. But when you're talking about somebody who has pericarditis, one of the things that you can do for these patients is to provide them the non-steroidal anti-inflammatory medications. So you're talking about medications such as ibuprofen, Indocin, medications that are non-steroidals. Just remember, you have to be careful when you're giving NSAIDs that you can cause gastric ulcers or gastritis, and I have experience with that if you'd like to hear that story sometime. Or you can cause renal failure. So if you have somebody who has borderline renal function, or they don't have great renal function, then you have to be alert to the fact that you can throw them into renal failure. So you have to be careful about using NSAIDs. Make sure that they're taking it with food. If they have a history of peptic ulcer disease, then you probably need to stay away from that. Okay. Colchicine is, and I encourage you to look up colchicine and read more about it. But colchicine, which we normally use for gout, is great anti-inflammatory effects. And so it's actually demonstrated to, and there are significant studies to demonstrate that you can actually significantly reduce the recurrence of pericarditis without the adverse effects by using colchicine. So these patients ultimately will probably get put on colchicine. Now you can use glucocorticoids such as dexamethasone or prednisone, but you have to first make sure that there's no bacterial etiology for it. Remember, with glucocorticoids, you're going to provide some immunologic suppression. So if somebody has a bacterial infection and you're suppressing their immune system with glucocorticoids, then you're going to allow that bacterial manifestation to continue, especially if you're not treating with antibiotics. So you have to make sure that you have excluded some type of infectious etiology, mainly bacterial etiology. Usually glucocorticoids are added on if as a secondary means of treating pericarditis if NSAIDs and colchicine have been proven ineffective, or again, there's some contraindications such as we talked about with NSAIDs. Okay, and it talks here about activity limitations. This is not that they do bed rest, but you certainly don't want extraneous activities or strenuous activities. And so you want to limit some of that activity as you treat them through the pericarditis to prevent recurrence. Post-cardiac injury syndrome, and this just relates to your patients who have post-cardiac surgery or trauma. So this is the patient who, from a traumatic standpoint, smacked their chest up against the steering wheel with a frontal collision. Now, I'll tell you, if somebody has a frontal collision, we're not talking about trauma right now, but they're going to have many other injuries associated with that, multiple system injuries. But if you smack your chest up against the steering wheel, then there's a risk that you're going to develop a cardiac contusion. And with that, you can develop pericardial tamponade. So if you have some injury to the myocardium, then there's a propensity for that myocardium, that part of the myocardium that's injured, to bleed into the pericardial sac. So you have to pay attention and be alert to that as they're admitted to the hospital. Certainly with cardiac operations, and I've talked about this before, where you have some type of invasion of the pericardial sac and or the myocardium, then you can certainly see bleeding. And despite surgical efforts to minimize any risk of postoperative bleeding, it can occur. I mean, it's just a known risk of cardiac surgery. So a lot of times mediastinal chest tubes will be put in place, but not pericardial chest tubes, mediastinum, so outside the pericardium and in the mediastinum. So if they bleed into the pericardial sac and there's no way for that blood to be moved out of the pericardial sac, then you can start showing signs of pericardial tamponade. Again, pericarditis tends to be fibrinous in nature, or more commonly, especially if it's something acute, you can see serous sanguinous or even sanguinous fluid. Okay. So your clinical presentation for post-cardiac injury syndrome, especially for pericarditis, is that you can see this anywhere from 1 to 4 weeks after cardiac surgery or the cardiac injury. You can see associated pleuritis and pneumonitis. And these patients, because of the inflammation, will demonstrate a fever associated. It may not necessarily be a fever to 102 or 103, but it may be just higher than normal. Remember, a normal fever is a normal temperature is 98.6 plus or minus 1 degree. So if you have somebody who has a higher than normal temperature, say to 100.4, then you may find, that may be a sign that there may be something going on. They're going to have the same type of pain as we talked about in acute pericarditis, with that left sternal chest pain, pain radiating to the arms, shoulders, neck. And again, it may subside as this inflammation subsides, and that may take up to 1 to 2 weeks, especially as you treat them supportively, and we'll talk about that. Again, you may see evidence of an increased leukocytosis, or aleukocytosis, an increased sedimentation rate, and then again the EKG changes we talked about earlier. Similar to the previous slide where we talked about management, again, these patients may, just treat them with NSAIDs as an anti-inflammatory, whether it's Motrin, Indocin, naproxen, some type of NSAID, as well as analgesics. You may want a narcotic in there just to help control the pain. But again, if there's no contraindication to the NSAID, the patient needs to understand that NSAIDs are important for the anti-inflammatory effect. And you got to tell them that, because a lot of times in the public setting, in patients who don't have any medical background, they're going to think of Motrin as a painkiller. They're not going to think about it as an anti-inflammatory. So you a lot of times have to educate them about the anti-inflammatory effects of NSAIDs, as well as the analgesic effects, and you may need to provide them a secondary analgesic so that their pain's relatively well controlled. Again, if you have issues of recurrence, you can think about colchicine, as we previously talked about, and certainly glucocorticoids. Just remember that glucocorticoids, they're your steroids. There are two different types of steroids. There are glucocorticoids and mineralocorticoids. So remember, steroids are not without their adverse effects. And so you want to be careful about whether or not you're going to be using the steroids, but they may help with the inflammation if you're having trouble with NSAIDs or colchicine. So when you're thinking about developing your differential diagnosis of acute pericarditis, your book pulls up some very important points that I want to just make sure you take into account. One, you want to be careful about mistaking an acute MI versus viral idiopathic myocarditis or pericarditis. When you have somebody who presents with pericarditis versus MI, those two are going to, when you're initially presented with this patient and they're complaining of chest pain, your history becomes very important. So making sure that you go through, ask them the questions, and understanding for pericarditis, especially if it's viral idiopathic, did they have a recent illness? Have they had recent fevers? Are there other things that are going on? Do they have any of the associated conditions for which you can have a non-infective pericarditis? Be careful about that, because you can lead somebody down a road of treating them for an MI when in fact, and put them on heparin and give them nitroglycerin and all the things that you're going to do, when in fact that's not their issue. Or the other way around is you sit there having in your mind they have pericarditis, and the whole time they have an injured myocardium and they're infarcting their myocardium because you haven't recognized that. So you need to really run through, get your differentials up, make sure they don't have a hard MI versus pericarditis, and go through your diagnostic testing to make sure you can delineate between the two. Pericarditis secondary to post-cardiac injury is differentiated from acute idiopathic pericarditis primarily by timing and history. So remember that with somebody who has acute idiopathic or viral pericarditis, usually there's some type of timing to the injury in relation to, and there's some type of association with a recent viral illness, versus somebody with post-cardiac injury, which it may occur within a week or even within a month after that injury. And look at the history. If somebody was in a recent car crash, now they're coming to you with complaints of chest pain, it may be somebody who has pericarditis versus from that injury versus somebody who has an idiopathic type of etiology or viral etiology. So look at your history. That's going to be your primary clues as to what the etiology of pericarditis is, and look at the timing. Okay. It's important to distinguish pericarditis from collagen vascular disease from acute idiopathic. And if you think about collagen vascular, you're thinking about scleroderma. My father died from scleroderma, and he had it in his he had cardiac manifestations as well as pulmonary manifestations. So you can see that from other rheumatic diseases. You can see issues related to pericarditis as a result. And so you want to be able to differentiate that vascular collagen disease from acute idiopathic. Remember I said that acute idiopathic is sort of your diagnosis of exclusion. So you want to rule out these other causes, because if there's a particular cause or etiology that's causing the pericarditis, you need to treat that underlying etiology. Okay, so that's why it's really important to use acute idiopathic as your last resort. Purulent pericarditis typically reflects a complication of cardiothoracic surgery. A lot of times, unless you have just this translocated bacterial infection, a lot of times if somebody's had cardiothoracic surgery, and that's going to be in the history, and they have some type of purulent fluid coming from their pericardium when a pericardiocentesis is performed, then you can pretty much relate that there was probably some infectious complication that occurred. Okay. If you have somebody who has a high BUN and they have pericarditis from uremia, then usually that's going to be in the setting of renal failure. And you're going to really treat that by dialysis. The only way in somebody who has renal failure, you correct the uremia with dialysis. So if somebody has uremic pericarditis, then that's how you treat that. Okay. And then if you have pericarditis from neoplastic disease, then obviously that's secondary to the actual cancer itself. And the only way it's really hard once you have pericarditis from neoplastic disease. It typically becomes recurrent, especially the effusion that is developed from that. So you are typically not going to just know that it's from the metastatic disease itself, and you may have to repetitively treat that patient with pericardiocentesis if they develop an effusion. So there are different causes for chronic pericarditis, and you have pyogenic infections, chylopericardium, which you have some type of lymphatic type of problem where you have chylous output into the pericardium itself. Radiation therapy, obviously you have scar tissue formation, and so you can develop pericarditis from radiation itself. Mycotic infections, tuberculosis. So these are different reasons, usually related to more chronic disease processes related to that cause the pericarditis. And when you do a pericardiocentesis, if you have pleural effusion, an effusion present, the pericardial fluid can actually help you diagnose this kind of problem. So the next thing to talk about is chronic constrictive pericarditis. And this is where you start to see obliteration of the pericardial cavity with formation of granulation tissue after healing of a fibrinous pericarditis. So what does that mean? Well, you start to have this formulation of granulation tissue on the pericardium itself through the pericardial layers. And with that formulation of granulation tissue, you have this sort of constriction that occurs as a result. And that constriction ultimately affects the myocardium in the sense that you have a decreased amount of space for ventricular filling during diastole. So if you think about it, it's a constrictive problem where you're starting to have less space available for the myocardium to really relax and to be able to fill with blood during diastole. And you can see here the primary etiology in developing countries tends to be tuberculosis, whereas you don't tend to see that problem in the United States as much. And so you tend to see other issues, and you can see here a lot of these are similar to the previous slide, but you have a chronic nature for the pericarditis that you tend to have just this damage over time to the pericardium. And with that damage and that formulation of granulation and scar tissue, you have this constriction or this contraction of the pericardium. And again, if you think about contraction of the pericardium, that's going to play a key role in ventricular filling during diastole. So again, pathophysiology, the ventricles can fill unimpeded in early diastole, but as ventricular filling continues, then it becomes reduced abruptly once that elastic limit is reached due to the rigid thickened pericardium. So initially you can actually see unimpeded filling, and that's when the ventricles are empty. But as you reach that critical point where the ventricles are attempting to expand with that filling during diastole, and you've reached that limit with the pericardium, then filling all of a sudden abruptly decreases to almost zero. So how is this different from tamponade? Well, just remember that in tamponade you have this progressive filling of the pericardium with fluid, and so as it fills more and more, you start to have impeded filling even in all phases of diastole. So that's where the difference really occurs, is that you don't have that progressive of decreased space to where you can't have any type of filling that occurs as you see in tamponade. All right, so this is, you still have some level of filling, but then it all of a sudden abruptly ends. You can see that ventricular end diastolic and stroke volumes are reduced because you have decreased amount of space, you have decreased filling, and therefore your stroke volumes are going to go down with each contraction of the ventricle or each systole with ventricles, and you have decreased ventricular end diastolic volume because of what we just talked about up here. Okay, you can imagine that if it becomes to an abrupt halt, that you're not going to have as much volume at end diastole, and so when your ventricles start to pump that volume, whether it's a right side into the pulmonary vasculature or whether it's a left side into the aorta, your volumes are going to go down substantially. Okay, so again, end diastolic pressure in both the ventricles and the mean pressures in the atria, pulmonary veins, and systemic veins are elevated to similar levels. So you tend to see this as well with cardiac tamponade, but again, you're not going to see it to the level that you see it with tamponade because you're not getting as much pressure as you see with tamponade in constrictive pericarditis. Clinical findings, you're going to see more chronic systemic or chronic findings where you have fatigue from decreased cardiac output. You're going to have weakness, that chronic illness sort of appearance because they just don't have the blood flow to really meet their needs. You may see a weight gain associated with this, increased abdominal girth, a protuberant abdomen, exertional dyspnea because of the limitations on the, ventricular filling and output. You may see neck vein distension and congestive hepatomegaly. The book makes a good point about distinguishing liver cirrhosis versus constrictive pericarditis. If you have somebody who has liver cirrhosis, you're not going to see the neck vein distension. You'll see congestive hepatomegaly potentially because you have and we'll talk about this in the GI series, but you have, or probably next semester actually, but you're going to have my apologies. You're going to have backflow of blood, and you're going to have increased size of the liver as a result. But again, the backup of flow is going to be in the portal venous system when it's liver cirrhosis. So when you have congestive hepatomegaly with constrictive pericarditis, you're going to actually see neck vein distension because the issue is at the heart versus the liver. Okay, so that's where you see the difference between the two. And I put on the bottom tricuspid regurg in an early S3. And I would say, why is that? Because you do have some, with that abrupt cessation of fluid, you're going to have some backflow into the tricuspid valve. Initially, you may not see where you may not hear that evidence of tricuspid regurgitation, but eventually you will start to hear that as you have weakening of that valve, and you're going to see some backflow. So remember, when you hear tricuspid regurgitation, if you think about where when you're going to hear it, you're probably going to start to hear it in systole. Okay, so it's going to be an S2 sound. It's going to be a murmur that you hear in the tricuspid area. So when diagnosing constrictive pericarditis, there's a few different tests that you can perform that may help you delineate whether this is a constrictive issue versus a non-constrictive pericarditis. If you get an EKG, you're going to find low voltage QRS complexes. And if you remember back to that slide where we had electrical alternans, if you have low voltage, then you're going to see a smaller QRS complex. You may see flattened T waves as well. On chest x-ray, you may not find anything grossly abnormal, although you might see slight cardiomegaly. But on CT scan, and you see that I have this starred, you may see signs of pericardial thickening. Okay. And this can also occur with impaired ventricular filling of other etiologies. So pericardial thickening of itself is not always just constrictive pericarditis. But if you have the signs of pericarditis and on CT scan you see pericardial thickening, then this will aid in your diagnosis of this being a constrictive pericarditis. Okay. The other piece of it is, or the other main test you can do is transthoracic echocardiogram. You may certainly see signs of pericardial thickening. You'll see dilation of the inferior vena cava, and that kind of makes sense when you think that you don't have full filling of the ventricles at diastole, like we talked about on the previous slide. So you're going to see that backup of fluid back into the venous system, and so you're going to see a dilated inferior vena cava on echo, as well as if you can see the hepatic veins, they'll be dilated as well. And that makes sense when we talked about the congestive hepatomegaly that we talked about when discussing the difference between liver cirrhosis and pericarditis, constrictive pericarditis. You will see normal systolic function. I know at times with tamponade we talk about that you'll see that you can't get the flow out and you may some systolic dysfunction. But remember that these patients don't have a specific systolic dysfunction that's occurring. The ventricles can actually pump normally. It's just that they don't have the volume of blood, and so that you'll find that their systolic function is actually okay. Their ejection fraction will be typically greater than 55%, which is the lower end of normal. And like I talked about with pericardial tamponade or pericarditis as well, that you may see flow velocity changes on the echocardiogram. And I don't really expect you to know much more than just that there can be flow velocity changes. Okay, so this is a MRI with where you can actually see evidence of pericardial thickening that's occurring along this wall. Okay, so I just wanted to show you what pericardial thickening can look like. This is what we call an axial section or an axial view of the chest. Axial meaning that you're actually cutting through from anterior to posterior, and you're actually looking at a cross section by cutting anterior to posterior. So this is an axial view, and again, if you'll see where the arrow is pointing and I'm pointing with my arrow, that thickened wall is in this case likely due to constrictive pericarditis. So differential diagnosis for constrictive pericarditis: cor pulmonale, which you can normally see with advanced chronic obstructive pulmonary disease that leads to right heart failure. Usually in cor pulmonale, the heart is not enlarged, and you're normally going to see evidence of advanced parenchymal disease, and that's why I said advanced stage COPD. Normally you have some evidence that somebody has advanced stage COPD, and you'll notice that if you look through the echocardiogram that the venous pressure falls during inspiration. So essentially, if you have the picture of advanced stage COPD, and again you don't have that cardiomegaly, that they may have evidence of cor pulmonale instead of constrictive pericarditis. Tricuspid stenosis, if you think about the tricuspid valve, which is from the right, which is the pathway from the right atria to the right ventricle, that if it's stenosed, meaning that it can't open that well, then you're going to have backup of fluid back into the venous side. So so if you have somebody who presents with distended neck veins, hepatomegaly, that's congestive in nature, then tricuspid stenosis and constrictive pericarditis may be your differential diagnosis. And then an echocardiogram may be able to delineate whether or not you have a stenotic tricuspid valve that you can't get flow through, versus it being a constrictive pericarditis. One other thing you'll notice is that you'll have a diastolic murmur at the tricuspid valve area, which is usually about your fourth intercostal space, left sternal border, third or fourth. And so in this kind of case, your physical exam is going to be of benefit, because when you listen to heart sounds, then you'll actually hear a diastolic murmur. That's okay. And then finally, remember, mitral stenosis you'll typically have along with mitral stenosis. So you actually may hear a diastolic murmur at the mitral valve area, which is usually close to the apex. So lastly, restrictive cardiomyopathy, you may see fairly similar signs, but when you look at restrictive pericardiomyopathy, you're going to have ventricular wall thickening, not pericardial thickening. So echocardiogram and potentially CT scan may actually help you delineate whether this is a restrictive cardiomyopathy versus a restrictive pericarditis. Okay. You will have evidence of left heart failure with orthopnea in restrictive cardiomyopathy, whereas in constrictive pericarditis, you're not going to have, you'll have fairly normal, or if not absolutely normal, LV function. And because you have normal LV function, you should not have evidence of orthopnea. And then you can definitely hear a distinct apex beat. So what's the treatment for constrictive pericarditis? Medical treatment is going to involve sodium restriction and diuretics. And the reason for that is that may help with excess fluid that you may be worried about. Probably the more definitive treatment that would be important to know is that because it's a constrictive chronic pericarditis type of scenario, constrictive pericarditis, that resection of the pericardium may be necessary. And you can see on the screen that operative mortality can be in the upwards of 5 to 10%, and even higher if you're in the advanced stages of this disease process. So if this is something that's caught fairly early, to take care of it early would probably portend a better result or a better outcome overall. Okay. So let me know if you have any questions regarding this lecture. I appreciate your time in listening to it. It's a little bit long at around an hour and 25 minutes, but I think it really encompasses the material that you'll need to know to better manage these patients with pericarditis. Thank you for your attention, and I will talk to you soon. Take care. Bye.